started. So welcome to anybody joining for this particular webinar, and welcome back to those that have been with us throughout the day. So this is the final webinar of the day, and it's presented by Penny Townsend. It's on paediatric moving and handling and complex risk assessments. So quite an impressive bio from Penny. Penny's an advanced member of the National Back Exchange. She's a paediatric moving and handling consultant with over 19 years of experience working in both special and mainstream schools, as well as respite care settings. So Penny provides moving and handling training, advice and problem solving on complex moving and handling situations. She's also an independent paediatric physiotherapist specialising in neurodisability. So her experience has been gained in a variety of different healthcare settings, including acute, community and local authority. So you may also recognise Penny. She's spoken at many national and international conferences, including National Back Exchange, where she won the Workshop of the Week back in 2018, and also has several articles published in Column, which is the journal for National Back Exchange, for those not familiar with it, as well as peer-reviewed and co-authored subject matter books and publications. So Penny, over to you. You are muted, Penny, but I will unmute you, I think. While you're unmuting it, I'll just remind everybody that if you do have questions, please use the Q&A section at the bottom of the screen. So there is a chat function where you can chat amongst yourselves, but if you would like a question posed, it's important that you use the Q&A section box so that we can answer and address any questions efficiently and capture them all.
Right, can you hear me?
Yes, perfect.
Brilliant. Okay, so actually, I don't need to introduce myself now because you've just done a wonderful job for me. So good afternoon, everybody. My name's Penny Townsend, and obviously I've had that wonderful introduction. So we will just crack on with the presentation. So the aims today are to assist participants' understanding of children and adults who present with profound complex needs, and to improve your knowledge to undertake complex risk assessments. Now, I know a lot of you will already do risk assessments, but when we're working with the group that I work with, is that then there are other considerations that we often need to take into account. And the one thing that I said, what Julie said just before the presentation went live, was that remember, if you don't work with children and you think paediatric handling isn't for you, they do become your service users of the future because they are surviving into adulthood with very profound complex needs. So that's the aim of today. I'm going to try not to rush through everything. So if I do say something that doesn't make any sense, then put a question in and I'll try and answer it at the end. So there's the bit about me that Julie has already kindly said. I never set out to be this person, but somehow it's happened along the way. If you cut me in half, I'm half physio and half moving and handling professional, but it does depend on the day, because some days I'm more physio than I am moving and handling. But I don't have all the answers either, because there are always children's clients that will surprise me and can't always solve the problems, but we can make things a little bit better for them. So the learning objectives that I sort of said was legislation. I know if you're moving and handling professionals, you'll all already have a deep understanding of the legislation, but it just was an overview to set the framework of the session. I've also included understanding roles and responsibilities in line with the HCPC guidance, because that actually is something that comes up on a regular basis in my role as an independent moving and handling consultant. And then looking at the complex risk assessment process and perhaps other things that we need to consider than just the standard risk assessment process, and then the safety considerations. So what makes it more difficult carrying out a risk assessment for somebody with complex needs? Now, obviously, I'm talking specifically about paediatrics, but they do grow into adults, and you can have adults with complex needs as well that are conditions that are neurological conditions that they then get later in life. So the risk assessment process that I'm talking about in paediatrics would apply to somebody like Parkinson's with MS or MND. So it's looking at how the movement patterns change. So we'll talk a little bit more about that later on. So Relevant legislation. I know that you all know about the relevant legislation, but obviously the Health and Safety at Work Act is our overarching framework to make us do safe things related to moving and handling and just health and safety in the workplace. So the moving and handling operations regs, again, for me in paediatrics, it causes a little bit of discussion a lot of times when we're doing risk assessments because of children and do we manually lift them or don't we manually lift them? So there are still places I come across where they will say manual lifting is banned. I can think of an example, a transport team that I was working with, and their policy said that they expected the parents to lift the children on and off the school transport, and at the other end it would be the school staff, but they had a policy that said manual lifting was banned, and actually we all know that that's not lawful, but trying to make them see that what they had written down was unlawful was quite a battle and a bit of an uphill climb, but we did get there in the end. The lifting operation and lifting equipment regs, so around our servicing and provision of use of equipment regulations. And there's then many more that feed into the decision-making process, certainly when handling children. So the things that we need to consider, and this is where I'm just going to look at my book because I made a little bit of a list because I didn't put them on this slide, is that we've got to think about the Mental Capacity Act because it's something that keeps cropping up in my workplace on a regular basis. Now, the Mental Capacity Act doesn't apply to children at all. So it applies to children who are over 16, and children who are 16 to 19 with special educational needs will stay in provision until they're 19. So then the Mental Capacity Act does apply to them. But also then we have to consider making decisions in their best interest to keep them safe. But actually for any child that is 16 and under, it is for the parent to make that decision about what is in their best interest. And it causes quite a lot of arguments, or disagreement, shall we say, between services. So I'm going to now demonstrate, this is for your titillation in the afternoon. So here I have a young lady who is called Julie, and she is in a wheelchair. She's got a lap belt on, she has a chest harness on, but what she likes to do is throw her legs up in the air like that and put them over the side of the wheelchair. So can you all see that? Yeah, so she waves her legs around. You never know when she's going to do it, and she does it sometimes as she is going through a doorway. So the risk there is that she may hit a leg and injure a leg or fracture it because she has problems with her bone density as well. And her mum had asked just to have a strap put over the top of her legs. So she's got a lap belt on, keeping her safe in the chair, but something just to keep her legs in the chair, because the other thing is she can get out of her foot straps as well. So having her feet fastened in doesn't help her. So there was a big discussion with wheelchair services who refused to put a strap on because they said it was a deprivation of her liberty under the Mental Capacity Act. But she's only 10 years old, so it doesn't apply. But trying to get them to see that what we were trying to achieve was for her safety, and we weren't depriving of her of her liberty. Yes, we were depriving her of the ability to wave her legs around in the air, but it actually was for her safety and to help her regulate her emotions, because actually she does that when she's very dysregulated. So when I'm doing risk assessments, there are lots of other bits of legislation rather than our standard moving and handling bits that I'm trying to think about. So the Mental Capacity Act doesn't feed into it, but the Children's Act does as well. And we've also got human rights and all the local policies and procedures. And it's making sure that the local policies and procedures are ensuring that when we're doing a risk assessment for these young people, that we're making it in their best interest to allow them to achieve things. So again, some of the things around the equipment and equipment provision is that sometimes we have moving and handling equipment that then isn't compatible with their seating systems. So it's making sure that we're thinking about all of those things when we're doing our risk assessments, especially about equipment provision, and is it compatible with one another? And then again, coming back to sort of kind of that mental capacity thing, again, thinking about somebody who's a little bit older, in the school. So he was 17. He was a looked after child and he was living in a residence. And one of the things, he was autistic, and one of the things that he would always do is run off if he was out in the community. So the staff had said that they wanted a handling belt for him so they could still take him out and keep him safe. Now, I'm not the biggest fan of seeing handling belts used like that, but so to do the assessment, I went out into the community with him and with the staff, and we walked up the main road, and he had his hand held, so he was holding hands with his support worker, and he decided that he was going to get out of a handhold and sprint up the road whilst taking his shoes off at the same time and throwing them in a wheelie bin. So he sprinted up the road towards a set of traffic lights. The support worker was going after him. I said, I'll get the shoes out of the wheelie bin, don't worry about it. Instead of tipping the wheelie bin up, I leant into the wheelie bin and ended up head first in the wheelie bin just as the bus pulled up along the bus stop with me with my legs sticking outside the wheelie bin. So although that was a very comical moment, it was everybody on the bus was laughing. So the thing was, I then said, yes, he definitely needs a handling belt, because it gave them an extra way of hanging on to him, because he could get out of their handholds that they were using. So then he moved provision, and the new home that he was living in didn't like the fact that he was using a handling belt for those transitions in the community, because they didn't feel it was age appropriate, and because the Mental Capacity Act applied to him because he was 17, is that they felt it wasn't in his best interest to have the handling belt, and they said that they were safe enough to take him out in the community. So it was down to their risk assessment, but I still think that they weren't thinking about how they would keep him safe in the community if he did decide to leg it, because when he legged it, he legged it. You all know what legging it means, running as fast as you can, basically. It's a very Yorkshire word, legging it. And I'm not proper Yorkshire, but I do use a lot of Yorkshire words. So when I'm considering risk assessments, I'm considering lots of different bits that feed into that. And part of that is with my physio head on as well. So I hope everybody's okay with that and they don't need me to say any more about the legislation, because it bores me, really, to be honest. I shouldn't say that, should I? Being a moving and handling consultant. So I've put this slide in, roles and responsibilities, and it's around, I've missed the letter off, it's the HCPC guidance. So it's the Healthcare Professions Council guidance, and it changed in September 2024. Now I've put this in because in my line of work, I work a lot in the independent sector, and I come across a lot of independent therapists, OTs and physios, who maybe are sole traders, or they might have a physio business. And what they often will do is they will put a package of care together for a child who's got support workers, and then will say that they can deliver the moving and handling training. Now, they are not qualified moving and handling professionals. They are just the therapists. So it irritates me, is what I will say. It irritates me because actually it's dumbing down our profession as a moving and handling professional if other therapists think they can just deliver moving and handling training because they know the child really well. So I always will say to them, is when I come across the situations, is that you need to make sure if you are delivering that training, you must have a moving and handling qualification yourself to safely deliver that training. If you don't, you need to refer it on to an appropriate professional. So there are lots of people that I know will deliver training without a proper moving and handling qualification. Yes, they've got loads of experience and knowledge of disability and that family and how that child moves, but actually it should be around joint working with somebody who has got the moving and handling skill and the ability to train the care staff. The physios can still train them in the therapy activity because they're delegating that therapy activity to the support workers and the family so that the child has physio every day. But actually, they shouldn't be delivering moving and handling training if they haven't got that moving and handling qualification. And it crops up more regularly than I'm happy with, really. So the HCPC guidance says that you should work within the limits of your knowledge and skills, and only practice in areas where you have the appropriate knowledge, skills and experience to meet the needs of a service user safely and effective. effectively. So if you haven't got that skill, then you can undertake additional training to get yourself skilled up. So when I come across people like that saying, oh yeah, we do the moving and handling training, I'll say, so have you got insurance? Have you got a qualification? Where's your CPD to back up all that? Oh, I haven't got that. Right, well, if you want to do moving and handling training, then go and do a train the trainer course, and then keep your CPD up to date. Join National Back Exchange so that you're aware of what the best practice is in the UK and beyond as well. And some people take me up on it, and some people still like to wing it. And the other thing is, I work very much in medical negligence clients, both as a physio and moving and handling. And a lot of the case managers that are putting a package of care together for a client, and it doesn't matter whether it's a child or an adult, will often go to the therapist to ask them, and they put pressure on the therapist to deliver the training. Now, the therapists that are really up to date and skilled will say, actually, no, we need a moving and handling professional. It's not my knowledge, but there are some therapists out there, maybe they're only new into independent practice, so they will take it on because they think they're doing a service, but they're putting themselves at risk from a roles and responsibilities point of view under our guidance. So if you do have somebody like that, is you must refer your service user to an appropriate practitioner, but also know that that practitioner has the skills and knowledge to deliver that training. So it's seeking those people out. So I hope that makes sense. I know it probably won't apply to a lot of you who are listening today, but for me, it's something that comes up a lot. And I am very conscious as a moving and handling professional that we don't dumb down the knowledge and the skills that we have and just say, well, anybody can do moving and handling, because that's not the case. It's a bit like saying anybody can do physio. Well, that's not the case either. So for me, that's a really important slide. So how am I doing for time? That's the other thing I can check, because I can waffle on forever. So I'm looking, I have my own special audience either side of me, and I keep looking at them just to check that I'm going all right for time. So a risk assessment, you're all very familiar with that TILIO or LITIO or whatever other acronym people want to use, whichever way around they put it. So for me, obviously the task is the information. What is it we're doing with that child? Where are they transferring them from? What equipment are we putting them into? But actually, I think risk assessment is a word that scares people quite a lot. And I have staff that I work with in special schools, and they're trained in how to carry out those manual handling risk assessments, because I'm not always available. But with the new staff, they're always scared of risk assessment, because they always say, well, if I put it down on paper, does that mean I'm responsible if something goes wrong? So I try to get them away from being scared about those words, risk assessment. Because I know when I first started as a moving and handling professional, I was a bit like, oh, risk assessments. Oh, no, that's not my job. But actually, it is my job. So I don't think of it as risk assessment. I think of it as problem solving. And then it sounds a lot less scary. So if we're doing a risk assessment, we're actually problem solving a situation that isn't working quite how it should be. And we're looking to see how we can put things in place to make it safer. So I'm looking at the transfers that those children might be doing. Obviously, individual capability is looking at the people that are providing the support and doing the transfer. But actually, when in the paediatric population, and we should do it in the adults as well, I'm always looking at what they can do for me as well. Because one of the things, if you can look at somebody, a child in a wheelchair, and you can sort of see them sat there and they're a little bit non-responsive, they might be non-verbal, they might have cortical visual impairment. You might think that they can't understand you. And you look at them in the wheelchair and think that they can't do anything. So actually then you do this risk assessment and says, oh, well, yeah, they're going to need to be hoisted because they can't join in. So you should never just look at somebody in a wheelchair and presume that they can't do something. So I've got a young man, I'm now his physio, but I knew him initially from a moving and handling point of view at a special school. And you would look at this young man, Alfie, and think, no, he can't. He's, his head's flopped to one side. He looks really low toned, really, really floppy. But actually, Alfie could stand transfer if you got him in the right position. But initially, when he came in school, all the staff were saying, oh, he needs hoisting, because they looked at him and just presumed that he couldn't do stuff. So for me, my assessment process is always looking then with a little bit of that physio head on to see what they can do. And it might be that it's only turning the head to help them roll, or the head is turned to one way, so I would roll them that way anyway. It might be that they can put an arm over the chest. It might be that they could cross the legs. So trying to see what they can do. Some children physically can't assist at all, you know, because of their complexity, but it's always to give them that opportunity to join in and be part of that process for if they've got very complex needs. So then in terms of the load, obviously we're looking at the weight and the size and the shape and the complexity of body shape. And then for me, the other thing is the safety considerations around bone density issues. So when I'm thinking about the load, I think in adults, you sometimes just kind of think, maybe in barrier plus size people, is that you might be thinking about their weight, but with children it's not so much about their weight, it's about the shape due to their contractures and deformities they have that make them an unusual body shape. And then thinking, actually, if they're such an unusual body shape, could I roll them for personal care, for example, or for fitting a sling? So that all feeds into the risk assessment as well. In fact, I met a young man years ago, went to do some training. He's unfortunately no longer with us, and I have never met anybody's so contorted, and his sort of kind of top half was really rotated round one way and his bottom half was completely round the other way. And his mum had said to me, in the training, you won't be able to get him to roll because we can't roll him, it's not physically possible. And me, being the naive moving and handling person, went, of course we'll be able to roll him, of course we will. And actually it wasn't physically possible to roll him. He was very light, so actually that wasn't a problem, because all we were doing then to fit his sling is just doing a little lifter off the bed and sliding the sling underneath him, because he wasn't heavy. But because the complexity of his body shape, we couldn't actually physically roll him. I do think now, sort of as we've gone through, sort of kind of, I suppose I've matured in my profession as well, is there are bits of equipment now that I think actually probably could have helped us roll him. So for example, the assist sheet bar from GB UK, I think I would have been able to roll him in that and actually kept him comfortable. So obviously the other thing within your risk assessment is your environment, space constraints, and whether you're doing the activity inside and outside, because obviously children love to go out and play. Some of my most complex risk assessments are things like getting on and off slides, on and off swings, getting into ball pools, you name it. I think I've probably got in and out of it with a child and tried to find a safer way to do it, and hoisting outside, for example. So looking at that, and for me as well, when you're working with children, is there are often lots of other children in the house as well. So environmentally, that can have an impact. So I've got a young physio client, and she's got a younger sister who loves to come and watch the physio, but while we're doing physio, she's climbing on me, she's hanging off the spreader bar, she's climbing up the tape of the hoist. So actually sometimes my environment is to do with actually what's going on with children. So when you're working with children, you tend to have more children hanging around and getting in the way sometimes. So actually sometimes that's what you need to think about from your risk assessment point of view. And obviously other is anything else that impacts on the handling task that isn't included in the other headings. One of my classic ones was a very glamorous lady who worked at a special school, and she loved to wear very low cut tops, so obviously not very appropriate, and short skirts and high heels. Now she always looked amazing, but actually when we had to do risk assessments around her fitness to practice, it was her clothing that was a problem. And so much so that the school had to come up with a dress code policy which changed it for everybody else, so that actually she did retire then. Actually I think it was just she liked wearing her short skirts. So there's sometimes the other things that you need to think about. So for me, the other things that I always consider when I'm doing a complex needs assessment is looking at the functional independence measure, which again, that's all in the Moving and Handling Children book by NBE. So obviously 7 to 1, so complete independence to 1 to total assistance. And I will put that in my handling plans that I now do for case managers, so that they can get a snapshot straight away without having to read. I'd like them to read all the blurb, but actually that's the first thing that they can see, is that actually this person is independent, or no, they're not, they need some assistance. I also include the Likert scale for handlers and those being handled, so we can sometimes work out how comfortable it is. And with children with complex needs and young adults, is a lot of the time they might be non-verbal. So although you couldn't then do the Likert scale for them, but you're watching their facial expressions, listening to the parents know their children really, really well, and they will tell you whether they're in pain or not. So if you're just doing a snapshot, it's really hard. But when you've known somebody for a long time, is that then you can understand their communications by watching their face. So you can actually understand whether handling is easy, is comfortable for them, or it's very uncomfortable. And again, I'm going to use one of my physio clients as an example. So I've known Ben for 19 years. He'll be 21 this year. So I've worked with him since he was 2 years old. He has got hoisting equipment available in his house. He's got a ceiling track hoist and he's got an in situ sling. But his dad still, at the age of 21, his dad still wants to manually lift him out of the chair and put him on the floor for me to do my physio with me. And it's something Dad has always done. I can't persuade him otherwise. I'm there as the physio, not as a moving and handling professional. I do try when I see him do it. I mean, Mum is really good now. The sling is underneath him, so I generally hoist him onto the floor, but Dad will still lift him. And if I watch Ben's face when he is being moved to the edge of the chair for Dad to scoop lift him, Ben's face is a picture of discomfort. And he purses his lips and his nose rises up, and you know that that's his face of pain. And I will say to his dad, he's really not very comfortable with that. So, you know, it would be better if we hoist him. And if I hoist him, his face is relaxed. So I know that being hoisted is more comfortable for him. So it's not always about asking those questions. It's about watching people's reactions as well to work out whether something is comfortable or uncomfortable. Obviously, there's the broad perceived effort scale. I probably use that a little bit less. But I sometimes will question carers when they'll say, oh, it's really, really hard. And then you'll say, well, give me a scale of how. So, well, if we do this, is it easier? No, it's still really, really hard, because you just get those people that just, they want it to be hard. They just like moaning. And then the big one for me, which is not recognised in terms of moving and handling, but it's a physio I use. It's called the Gross Motor Function Classification System. There's a reference on the last slide to it. And it basically gives children a level of 1 to 5 for different ages within their different periods within their life. So 0 to 2, 2 to 4, and so on. And it goes up till they're 16 to 18. And so if you are a level 1 GMFCS, that means that you're relatively independent and you might have some limitations. So it might be the children that have got cerebral palsy where they're hemiplegic and it just affects one side. To level 5, which is your most severe. So actually I put that in my risk assessment again for that snapshot to say that this risk assessment and handling plan that I might generate from that is going to be quite complex, because we've got a very complex child because of the disability that they have. I hope everybody is okay with those tools. There is a picture of the risk assessment pro forma that's in the Moving and Handling Children's book. If people are daunted by doing problem-solving risk assessments, I sometimes say to them, use that, because it's a really easy way to get into doing that problem-solving and risk assessment process. So everybody should buy the Children's Moving and Handling book, basically. I don't make any money out of it. It's all to MBE. It's all to MBE. So one of the things around handling plans, risk assessments, is sometimes there is so much stuff there or not enough. I know that in Yorkshire Back Exchange, we did many years ago, we had a meeting where we all shared our handling plans and our risk assessment pro formas. And there had been a court case where a judge had deemed the handling plan and risk assessment to be too simple, because it just said hoist with 2. Now, you and I know what that means, but actually for a carer working with somebody, what does hoist with 2 mean? So if to somebody who's uninitiated, it doesn't tell you anything about how that person should be moved. So I do think paperwork should be clear and simple, but you do need to have enough information in there to inform those people who are going to be doing the moving and handling tests to know how they're going to do it, where they should put the wheelchair, should they have the brakes on, should they have the brakes off. All of that stuff should be in that handling plan that you form after you've done your risk assessment. And make your risk assessment suit your service users. Use your clinical reasoning as to why that risk assessment works, because sometimes I think risk assessments become really black and white documents, but actually when we're handling people, there's a massive grey area, and your risk assessment is often subjective. So something that I might think is quite high risk is somebody else, another professional might think it's only a medium risk. So actually remember, it's your judgment as well. So it's gathering that information from the people that are supporting your clients, feeding into that risk assessment process as well. So are they finding it hard? Do they think it's a high risk activity, or actually do they think it's low risk and actually you're going, no, this is really, really high? So that feeds into your risk assessments as well. So I'm not sure what my next slide is because I can't see them. Right. Okay. One of the things that I just wanted to sort of talk about is compatibility of equipment. So one of the things that comes up an awful lot when you're working with children, it's all right when you get to be an adult size because the equipment is all adult size, but very few moving and handling companies make equipment. So for example, like transfer aids, standing transfer aids, make them for children. So there are some on the market that are good for small adults, but actually I might have a little one that I can assist to stand with two people, but actually you want to promote their development, and a stand aid would be really good if it was smaller, but actually they can't use it because then they can't get into their wheelchairs. Sometimes their wheelchairs aren't compatible with a stand aid device. So I can think of a young lady that I've worked with where she can pull to stand if her feet are fastened down and strapped in, and she can use her hands to pull up on a stand aid device. Worked beautifully out of her chair because she could reach forwards, but to get back into a chair, the base of the stand aid device wouldn't go under her wheelchair because it was a powered chair and the battery got in the way. So then she was too far away to get into the chair. So when we're doing assessments, we need to think about the compatibility of equipment. So it's all very well saying, actually, this piece of moving and handling equipment will work, but you need to check that it works with all of their equipment. Children, again, for example, that have wheelchairs that have foot plates that don't move out of the way, or posture work chairs that their foot plates don't move out of the way and you can't weight bear on them, but they can do a stand transfer with the help of one person, but we're then limiting their skills and their independence because the chair is wrong for them. So obviously we as moving and handling professionals don't prescribe the chairs, but it's about getting in there and having a discussion with the therapist about providing the right equipment so that we can actually make the moving and handling easier. Because what happens if they can't get in and out of their wheelchairs because of the foot plates, the staff will manually lift them in and out because they don't need to be hoisted at any other time, but they'll manually lift them in and out. So thinking about compatibility of equipment. The other big thing from a therapy point of view is postural care, 24-hour management, so sleep systems. So sleep systems are one of the banes of my life. They're brilliant to keep my clients' posture great, but actually from a moving and handling point of view, they are very difficult to retrofit any in-bed management stuff. So choosing your sleep system is very important to make sure that you're considering the moving and handling. So some of them, where the ones where you take the air out of it and it molds to your body shape, is that then if you want to roll somebody for personal care in the middle of the night, you have to take the air out of the sleep system and make it soft so you can roll them over, because you can't roll them in something that's been molded to their body shape. So actually that's not good for moving and handling. It might be a great sleep system for managing their posture, but it isn't great from a moving and handling point of view. So if you want to know more about sleep systems and moving and handling, that's a whole nother presentation. But we are doing a session at Yorkshire Back Exchange at our next meeting. So if you wanted to come and join us in Yorkshire for our meeting and learn about postural care and sleep systems and moving and handling, that's the meeting for you. So one of the things then for me this is my physio head on. How are we doing for time? Yeah, good. Is thinking about the complexities of the person that you're working with, and what does that mean for us when we're handling somebody, whether we're assisting them to fit a sling, when we're hoisting them, whether we're helping them to stand transfer. So for me as a physio, postural tone is something that I'm really passionate about. And if we were together in a room, I would be getting you to do all a little test on one of us to work out what your tone is. But basically, anybody with a neurological condition, so not just children, will have altered postural tone. This is not about muscle strength. This is about the tone that you hold within your muscles to keep you up against gravity. So everybody's tone is different. So there's a whole range of normal tone where some people will be slightly floppier and some people will be slightly stiffer. And then for anybody with a neurological condition, there will be two ends of the spectrum. So you have hypertonia, which is high tone, and that leads to spasticity and rigidity, to hypotonia, which is very low tone, very floppy, can't come up against gravity. You know, I've got young people that I've worked with where if they're laid on the floor, they can't even do something as simple as bring their hands together up against gravity when they're lying on their back. So they're very floppy. To make it more complicated is that some children will have a combination of tones. So some children will be very floppy in the middle, but then might have very stiff arms and legs, which pull them then into patterns of movement, which then give them contractures and deformities. So that's what creates their postural deformities. So postural deformities are things like flexion contractures at the knees and the hips, wind sweeping deformities, scoliosis. Postural deformities like that will lead to hip dislocation on a lot of occasions. So for somebody with really complex needs, which then feeds into that pain cycle. So if your hip is subluxing or dislocating, it can be very painful. And again, that's why it's really important to read people's facial expressions if they're non-verbal, and look at their whether they're sweating when you're moving them, because that can often be an indicator of pain. Sometimes children will vomit or retch, and again that will be an indication of pain. So your tone will then influence whether you have this, what the severity of your postural deformities will be. Often we'll have children who have got hemiplegia, which will have leg length discrepancies because they're not weight bearing on their hemi side as well. So that can then cause some problems as well in terms of transfers and making sure that their footwear is got a wet raise in it so that they're not wonky when they come into standing, so they don't fall over. Again, I'm leaving low bone mineral density till last because it's a big bugbear of mine. And then the other thing that makes handling more difficult is then whether you've got dystonia. So dystonia is where you go from being very stiff to very floppy all in one go. So you might go like that. I hope I've disappeared from the screen, to sort of kind of like that. So very, very, and they might do all sorts of funny altered body shapes and twisting and heads twisting round. And then sometimes they get locked in that position. So people will get their heads stuck, and then you can't get their arms in because their heads are stuck. So you have to work to get the head back to midline, and then that makes them relax. So that then from a hoisting point of view can sometimes be very, very difficult to achieve a good seated position in a sling. So your movement patterns and your dystonia and your extensive spasms sometimes make it very hard to hoist somebody. So even though our risk assessment might say the safest way to move and handle them is to hoist them, is actually it will bring in some other complexities of handling as well. So then athetoid movements are where you are constantly on the go, riding movements. People can't stay still, and that's really hard. They're often very, very skinny young people and adults, because I've got a couple of adult clients with athetoid cerebral palsy, and they are very tiny. So actually then they might be really, really long because they're adult sized, but they might be really, really skinny. So getting a sling the right size is sometimes quite difficult with those athetoid presentations. So the low bone mineral density is one that I'm really passionate about. So is if you are a child with a condition like cerebral palsy, Duchenne's muscular dystrophy, or any other genetic condition that stops you from weight bearing, you have to think the thing you have to consider from a moving and handling point of view is they are likely to have low bone mineral density. There is nice guidance on this in guidelines to managing children and adults with spasticity under 25 thing. If you do a Google, I think it's on a reference, so they'll tell you what is likely to cause low bone mineral density problems. So if you are non-weight bearing, so if you are non-ambulatory, is you are not going to have the cortical bone mass that you should have, like compared to a neurotypical child. So if you don't weight bear, so one of the things we do as physios is we put them in standing frames. Now, a standing frame with your hips in abduction is meant to be better for your hip development and bone density. However, is when you are in a standing frame, it isn't like normal standing. And actually what increases your bone density is impact force. So you need to be weight bearing. So you need to have that stamping of your feet to create that cortical bone mass. So if you are non-ambulatory, even if you go in a standing frame, consider they will have low bone mineral density problems. The other thing that feeds into that is if you are on anticonvulsant medication. So lots of the young people I work with have epilepsy as part of their profile, lots of genetic conditions have epilepsy as part of their profile, and anticonvulsant medications can affect bone density, where they reduce the cortical bone density mass. Being tube fed is also another risk factor, and children who are tube fed sometimes have low calcium and vitamin D deficiencies. So making sure that they get enough sunlight. And actually the thing with children and young people who are wheelchair users is people worry about them feeling the cold, even if it's a sunny day, because they can't move and exercise and get out of breath and heat themselves up, and they have sometimes have circulatory problems as well. So they're often wrapped up even on the sunniest day, so it only might be their hand that is sticking out and maybe a little tiny bit of their face. I go into lots of special schools in the summer, and it's very rare that you see bare legs on a children. So they're not getting that vitamin D from the sunlight, and actually in the Northern Hemisphere it's something we're all at risk of anyway. So all of those things will impact on whether they've got good bone density or not. If you've got low bone mineral density from a moving and handling point of view, that means that you're more likely to have a low impact fracture. So some innocuous moving and handling. So for example, picking the child up from the floor, if you thought they were little, so say they were 10 kilos, you thought, oh yeah, I can pick them up, they're only little, it's fine, because it's not band manual lifting. But your risk is, if you put a rotational force through their bone when you're manually lifting, is the potential you could cause a fracture. Dressing and undressing it is another thing that causes fractures in children with complex needs. So it's always thinking about having these things at the back of your mind when you're doing your risk assessment, and always suspect that if you've got somebody who is non-weight bearing, is epileptic, and actually if they're just non-weight bearing, I think should be the thing, is consider that they're going to have bone density issues, and you need to consider your handling, which is why then when I'm doing my risk assessments, I'm thinking about sling selection, because actually sling selection is then crucial to the comfort. So one of the things that increases your risk of fracture if you've got low bone mineral density is rotational forces on your long bones, and some slings naturally will put you into internal rotation as they hoist you up on your femurs. So you're potentially increasing the risk. So we might say hoisting is safer, but if we've got the wrong sling, we potentially could still be causing potential for harm to somebody. So it's nearly, is there a question and answer thing? Have we got a, yeah. Okay. So that really is me finished with that presentation, because I have gone through everything that I wanted to go through. So
thank you. I appreciate that. So we do have questions and answers section. So we've had a few come through on the link. A lot of it actually just seems to be around training, so you might cover a couple off kind of in one go. I'll start at the top though. So the first one we had in was, I'm a paediatric physiotherapist working in neurodisability in the community. I am also the manual handling link practitioner within my team, providing training to all members of our MDT. Our health and safety manager provides training to us link practitioners across the trust, which we then roll out as statutory and mandatory training. I have not got a specific manual handling qualification. I've looked for courses to get qualification, as I'd like this for my CV and to support my private practice also, but cannot find anything that I can access to get this qualification. Can you advise if A, I should be providing this statutory and mandatory training within my trust, and B, where I can get a formal qualification from?
Oh, that's a really good question. And what I would say is, if she's done a train the trainer course, that is your qualification. So if she's done a train the trainer course through her local provider where she's providing that training to, is then she's covered because she's done the train the trainer course. It really is a train the trainer course that allows us to train people. So back when I started as a moving and handling person, if this will help the answer, I think, in 2001, our local trust decided they wanted moving and handling trainers to do the link practitioner role like the ladies doing. And we were sent on a course to do a train the trainer course, and then we were going to be the link practitioner. So that's where I got my moving and handling qualification from. And then when I ended up being the moving and handling, so then I was still working as a children's physio, and my job was to roll out the training to our staff that were within the paediatric, which sounds like she's doing. If her health and safety person hasn't given her train the trainer course, I think I would be a little bit nervous. I'm looking at my colleagues here to my right and left. I would be a little bit nervous if she hasn't got that qualification and it's just been delivered by the health and safety person who's got a little bit of an idea about moving and handling. Is that it definitely needs to properly do a train the trainer course, and there are lots of train the trainer courses across the country, but again, it's finding a good provider, and a train the trainer course should ideally be lengthwise between 4 and 5 days. Anything less than that is probably they're not giving them the skills to then deliver training to others. So if she did that, she would then be able to practice privately as a trainer within her role as a physio. But hopefully she's done that in her work job, that they've actually sent her on a train the trainer courses, and that's why she's a link worker.
Okay. The next one, again, as I say, is
about
training.
Actually, I was going to say, sorry, it doesn't have to be specific to paediatrics, because there are very few paediatric train the trainer courses out there, and usually the ones that are out there are not delivered by somebody who is a paediatric specialist with paediatric knowledge. So, but if she just does a generic train the trainer course, that gives her the qualification then to deliver training to care staff.
Fabulous.
Okay.
So there seems to be very few courses available for current moving and handling advisors or leads to extend their skills or knowledge, or for experienced clinical, registered or non-registered staff wanting to get into a moving and handling lead role. Is there anything that can be recommended other than the course in Loughborough that is advertised on the MBE website?
Are we talking about just general training? And this is the thing from the question.
Looks like general training from the question.
Training. Well, general training again, it's you would go and do a train the trainer qualification or the Loughborough course. That is your choice. They are your choices in terms of being able to deliver training. So it's finding a provider that is doing the right length. Of course, it's a bit like the answer to the previous question. Is there is the Loughborough course, which gives you that if you want to go down the university route, that gives you that more recognised educational qualification, but then you can do the trainer course, join MBE, do the MBE advanced membership, which is then in line with the Loughborough course as it was back in the day when it first started out. So that's how you get that recognition from a training point of view, a qualification point of view. If you're looking in terms of paediatrics, there are no real courses on paediatrics. Some providers will run paediatric moving and handling study days, which will look at therapy handling as well as that traditional moving and handling aspect, because I know it's something that I provide, and there are a couple of other people that will do that as well. Yes, so yes, Sarah's just pointed to me, Edge do a paediatric specific course. In fact, when they set that up, they had me go and train their staff for 3 days back in about 2008, 2009. So it was a long time ago, but they used the information that I supported them with to then be able to run that paediatric course. I know a school that I've supported up in Edinburgh have been on the Edge training course, and a lot of the written information is very much in line with the paediatric moving and handling MBE children's book.
Okay. Would you advise to have a physical intervention training qualification as a moving and handling advisor?
depends how much of it you're doing, really. If you're working with a group where they have very challenging behaviour, then maybe it would be worthwhile having. I don't have one, and a lot of the moving and handling I get asked, certainly for our schools, is around those children with challenging behaviour. They're the ones that cause me the biggest headache, actually, if I'm truthful. Give me somebody in a wheelchair any day and I'm quite happy, but give me the children that run off or sit on the floor and refuse to move. So it might be, if that's somebody's, it's cropping up a lot in a role, it might be something that it's worth doing. I have in the past done a team teach course, which is about de-escalation and then sort of kind of holds to keep people safe. But what I found when I did the training was that there was very little talking about the de-escalation and the behaviour management strategies, and more actually just about the hold. So then my school staff would say to me, right, when do I start restraining them? And it's like, no, that's not the point. We look at the de-escalation first. So I think if it's something it's big within your remit, it would be worth it just because it gives you that background. I'm a great believer in the more knowledge you have, the better, to be honest, and the more you can upskill yourself, the better, because we should always be learning. Like I said right at the start, I do not know everything. I learn something new every week sometimes from carers that are doing handling day in, day out, because they're the people that do it more than I do. So I think, yeah, if you like learning and you want to gather that knowledge, it's the best thing that you can do is gathering knowledge, because it feeds into then your decision-making process all the time.
So kind of two wrapped into one for the next one. I've got one lady who said, what are your thoughts on people doing train the trainer qualifications who are not health professionals or have very little experience? And the question following that, kind of along the same lines, maybe if you wanted to answer it, totally, was interesting points re-qualifications. HCPC states you need to undertake additional training to update your knowledge. It doesn't specify attaining a specific qualification. Having worked in training for nearly 10 years, I still do not have a formal manual handling training qualification. However, did spend the best part of my first year in role closely shadowing a senior trainer, which I feel gave me more experience and learning than a train the trainer course. Happy to hear your thoughts.
Well, I would always say you get the qualification, because it's that thing that protects you from an insurance point of view. So if something went wrong and you ended up in court, the judge would say, what qualifications do you have? Now, experience is great, but from a legal point of view, I personally would be very uncomfortable doing what I do if I didn't have a qualification as a train the trainer. That is the only qualification I have. I have a train the trainer qualification. I don't have anything from Loughborough University, but what I've done over the years is built up a huge amount of evidence and CPD from all the things that I've got involved in. And I think, like the lady on the second question, is she's got loads of experience, and that is absolutely brilliant, and that is something that lots of us have. But I would feel very uncomfortable for her that she hasn't got a recognised formal qualification, as in I'm talking about train the trainer, nothing fancy like a degree or a postgraduate certificate. Because if you provide advice and a risk assessment and something goes wrong and you end up in court, somebody would say to you, you can say I've got all this experience, but people still want to know what qualifications you've got to make sure that you're providing your who you are. So what was the question before as well? Sorry.
The first one was actually around people who don't really have any qualifications or experience doing a train the trainer.
Yeah, I don't have a problem with that at all. I think, if you've got an interest, if you've been a carer for 5 or 6 years, moving and handling inside out for that person, is why not go and do a train the trainer course? Because the train the trainer course is there to help you learn to train other people, to teach you to train other people. So actually, anybody, you don't have to have a health professional qualification to do that train the trainer course, but what you have to have is an interest and a passion and a willing to learn. And then to go on and use it. So a lot of people will do train the trainer courses and then not use them, but use it as a bit of I've got a train the trainer course, so I don't need to listen to you on training because I've done it all before. That sometimes happens. But I would definitely say, yes, if you are a carer, you can do a train the trainer course. We've all got to start somewhere. That's the thing. I hear it quite a lot. I've got a client, she's a physio client, and her support team are amazing, and they're all very, very lovely ladies, and some young people as well, some young girls, so like their daughters help out as well. And when I'm speaking with the therapists, the OTs that help support her, is they'll say things like, oh, she's got a lovely team of carers, but none of them come from a healthcare background. And I kind of think, well, it doesn't matter that they don't come from a healthcare background. They're brilliant at looking after this lady and making sure that she's washed, she's dressed, she's clean, she's fed, she's got a lipstick on, she's got her nails done, she's in a wheelchair properly, they're using this postural support seating properly, and they're using the hoisting equipment properly, and they're using a sleep system properly. You don't need to come from a healthcare background to provide care for somebody, because actually that now they're getting that care background because they're doing it. So I personally think that if you are interested and you are a carer or somebody from any other walk of life that wants to do moving and handling, is do the trainer course, but choose the right course.
So what CPDs can be completed for trainers in paediatric?
Come on my study day. Come on my study day. There's a couple of us across the country that do paediatric study days. We often go to events like Kids Up North is often a good the kids events. So kids is spelt with a Z. So there's often usually a moving and handling presentation and a kids event day, and they hold them in the north, in Scotland, in Wales, in the middle, and down south. And I think, I'm not sure whether they do East Anglia way now. So there are those types of conferences that go on. Going to the OT show, there's often moving and handling things there. There's not always paediatrics, but sometimes if you pick your program well, you can find things. And again, it doesn't always have to be specific to paediatrics, because I would say some of the skills I've got, I have learned from listening to somebody did a moving and handling presentation on moving and handling in theatres. Now I might think, well, I'm never going to go to a theatre because I'm a children's specialist, but actually I learned something about a technique. Obviously the other place as well to go and get your CPD is the MBE conference that runs every September for 2 days. I often get roped into doing a paediatric presentation there. So that's again where you can find that paediatric support and knowledge. And again, the other thing I do is I would, if there's a group of staff that are interested in paediatrics, is then I come to people and do a study day for them in their work setting. I do that for quite a lot of NHS paediatric therapy teams. So there are opportunities. It's not just as common as maybe working with older people.
Okay, I've actually just one note on here. I'm a supplier and I've completed ROSPA level 3 to be able to do show and tell demos. So I do know that's actually quite commonplace for suppliers of equipment as well. Yeah.
Yeah, that's good.
Yeah. Okay. One lady's asking, could you tell us the name of the court case regarding the individual moving and handling assessment?
To do with the one where I said that there wasn't enough information, is that what she means?
Possibly. Maybe if you answer that in that context, and then we can always answer afterwards if that,
Yeah, off the top of my head, I can't remember. And it was such a long time ago that we had that meeting. So it was about 2010. I've been to sleep quite a lot since then. So I'll see if I can find it. But it was to do with that there wasn't sufficient information in. So a risk assessment should not just say hoist with 1, hoist with 2. There should be more information in it. And I've got people either side of me nodding their heads as well.
Always.
I will try and I'll try and find it. I'm not promising anything though.
Yeah, I can absolutely share, can't we, if we find any more information. So in terms of paediatrics, if a child is being harmed when being manually lifted against advice, is this classed as physical abuse?
Oh, that's a good question. So I can answer this really. It's a good question, but I can answer it really easily. It depends who's doing the lifting. So if it's a paid worker that's going against the advice of the professionals that are involved, so that could be somebody like myself or the OT or the physio, is if they're a paid worker and they're going against the advice of the therapist and the child is coming to harm, then potentially, and I'm only saying potentially, is a safeguarding concern. We shouldn't use safeguarding as a battering ram to make people comply to our wishes. That's the other thing as well. But if you thought a child was being unduly harmed, then it is perhaps a discussion with a social worker. If it's a paid worker, if it's a parent, the law does not apply to the parents, so they can move and handle their children however they like, because they are not paid employees and the legislation doesn't apply to them. So if they are, say, as a professional, you have decided that they need to be hoisted for their transfers and the parent is still choosing to manually lift them, they have every right to do so, whatever their size and shape, because the law doesn't apply to them. If you are concerned about the child's safety, all you can do is document it in your notes that you have discussed with the parents again around the safety of hoisting over manual lifting. And that's all you can do, is just keep documenting it, because that covers you from that professional point of view, that you have raised it with the parents. You cannot lead a horse to water and make it drink, and the legislation doesn't apply to the parents. If it was a paid worker, then that's a different ball game, if you are thinking that they are not following. But again, it's thinking that sometimes they do things because they have to think outside the box. And where I've been this morning actually to work before I got here, is the young lady that I work with does a stand transfer with a stand aid and is hoisted for some of her transfers. She's really compliant. She's got much better at using a stand aid transfer. They have hoisting in place now, which they didn't have before. But actually, one of the carers takes her out in the community, and there isn't always access to a change in places. They can't take the stand aid device with them, so she will do a stand-in transfer with her holding onto a sink. So you could say that actually she's putting her at risk, but actually what she's doing is allowing access to community activities. So it's that. So this is the thing with problem solving / risk assessments. It's about actually, when is it happening? Why is it happening? So it's trying to unpick that in terms of the question.
Okay, got a couple more. I'm just conscious on time. How common is low bone mineral density in the population of disabled children?
I can tell you the answer to that. So 77% of children with cerebral palsy, so this was only a study on children with CP, will have low bone mineral density problems. But then you've got to consider all the other groups of children. So the study was on CP children, but there are children with Duchenne's muscular dystrophy. They are at high risk. Osteogenesis imperfecta is a brittle bone disease, so actually that they're always at risk of fracture. So, and then any genetic condition where they're non-weight bearing. So for children with CP, it's 77% of the population, and the children that are so I talked about who are gross motor function classification system 3 to 5, are more likely to have bone density issues. Sorry, let me start again. So 3 to 5, they will have decreased bone density, and it's generally universal in non-ambulatory children with CP. And there was a study carried out in America, and the cost of fractures to the CP population in a year to healthcare was 13.8 billion in the US. And they did a study where there was 245 patients with CP, and 16% had a history of one or more fractures. And it is, so it's high.
Wow. Okay. So what bones are most likely to fracture with low impact forces if someone does have low bone density?
Okay, so it's the femur, so it's your thigh bone and your humerus. Your humerus from, can you see my humerus there? From usually dressing and undressing with tight, stiff arms, pulling clothes on, which is where dressing sleeves are brilliant because you reduce the frictional forces. People don't like them very much because it's just another thing to think about. But actually, if you've got somebody that has got low bone mineral density, you should be considering when you're dressing and undressing them. And then the thighs so the femur, the thigh bone, is usually from manual lifting or sometimes an innocuous knock on something. Or we had one where a child was coming out of the classroom in their wheelchair, and another pupil ran into the wheelchair and caught the bottom of their leg as they ran into them, and it caused a femoral fracture.
Okay, so the last 2 questions, it is back to training. So hopefully we can wrap this up. I'm a local authority children with disabilities OT, and we're increasingly finding circumstances where parents are providing single-handed care, but we are not trained in this. Can you recommend any courses? We're finding it really difficult to get any support from our manager who isn't a clinician.
So yeah, single-handed care, it's a mantra that's come about. So it's been around for a long time. I wrote an article in the column about it. So single-handed care is just moving and handling. So do your risk assessment, and it's just moving and handling. So I hope that answers the question in one simple thing. So it's not, single-handed care is not something magical. It should be the baseline for our assessments in the first place. And then if you need any more people because of the complexity, that's where your risk assessment feeds into it.
Okay, and last one, because we are out of time. Apologies to the person that's just put another question, but we do need to stick to the schedule. We can always answer that offline afterwards. And the final one that we had in the chat to complete was, if in the community and demonstrating manual handling techniques to family informal carers, am I right that I don't need any kind of train the trainer course as I'm demonstrating, not teaching?
Yeah, so if you're demonstrating, so lots of therapists do this. So I've got obviously colleagues that I work closely with. They won't have a train the trainer qualification or a Loughborough qualification, and if they call it demonstration, not training, they're fine. Perfect. They're demonstrating.
Okay, so we'll answer the final question offline. Yes, thank you very much, Penny.
I was worried that there were going to be no questions at all.
No, that was fantastic. So I am going to